there is a chat bar. If you have any questions for Dr. Maluccio, you please put them in the chat bar, and we'll try to get to as many questions as possible. The last half hour or so will be a support group meeting, and we'll have different breakout rooms that you can go into and speak to people that have the same net issue. So Robert, what do you think? Anything you have?
Yeah. Just afterwards, the chat rooms, the breakout rooms. We've got Ann Dabbs, we've got Dave Vickery, we have Rhonda Ayala, and Mary Ann. So we have enough folks to moderate those rooms. Once we're through the presentation and the Q&A, you'll see a breakout rooms will be enabled, and you can pick whichever room that you're wanting to go into. So I think we're ready, and we're fortunate enough today to have Mary Maluccio, a physician and surgeon, and also the medical director of NOLA-NETS, who's here. I'm going to let her give a more detailed description of what she's doing, because it's an exciting and growing program. So good morning, Mary.
Hey, morning, Bob. Thanks for having me. So I'm Mary Maluccio, and I'm a surgical oncologist by training, although most of my professional life has been in cancer programmatic development. And then I started very early in my career focused on what I considered marginal patient populations. Those are people that are somewhat unrecognized or disenfranchised by mainstream medical practice. And so rare cancer patients fall into that category. So I took over the medical directorship of the neuroendocrine program in New Orleans, also called NOLA-NETS, when the giant of a neuroendocrine expert, Eugene Woltering, was transitioning out of clinical practice. And so he's like a larger than life. And if you ever meet me, I'm really small in stature and probably a lot quieter than he is. But I really think that we both are strong advocates for patient care, multidisciplinary care, and certainly all in on marginalized patients, in particular neuroendocrine. So thanks for having me. Okay, so I try to do these talks. One, thank you very much for this talk, but I try to do this talk trying to saying, well, what is the audience potentially looking for, and what is the really kind of the mission of the group for which I am giving the talk. So say, for example, NCAN. And I think that one of the most amazing things about this organization is that they really promote patient advocacy. And patient advocacy can be a lot of different things too, but part of patient advocacy is being actually your own advocate, or a loved one or a caregiver being an advocate for you. And that's why I think that some of the conferences that they put together are as much for the patient as they are for some of the people closest to the patient, helping them make decisions. So I decided that I would just go and give several slides on just becoming an informed patient, and trying to cover maybe some of the things on how you decipher things from reports, and how you can help yourself put a list of questions down so that you can become a more informed patient when someone is trying to go over treatment options for you, because neuroendocrine is really all about treatment options and the unique features of any particular case that would make one option more or less appropriate for you as the patient. So the objectives of the talk, so that I can you can grade me on whether I meet the objectives of the talk. There are to identify the key pieces of medical information that drive decisions. And that is actually not unique to neuroendocrine. It's just a little bit more complicated in neuroendocrine, because there are a lot of variables, and the variables are different between primary and metastatic sites. So understanding the tumor grade and the stage, because in neuroendocrine, oftentimes the grade is actually more important than the stage. And so better understanding why you would take advantage of one treatment option may not be as much about the stage of the tumor, but about the grade. The fundamental questions on treatment options and alternatives, and better understanding why you need to understand all the alternatives or all of the options that are out there, and why you are or are not more appropriate for one. And that would include surgical versus non-surgical alternatives, which is usually a question that comes up at a lot of patient support meetings on why someone would offer you a surgical versus a non-surgical alternatives. And then obviously questions around systemic therapy, which would include both the somatostatin receptor analog therapy as well as the chemotherapy. And then when a second opinion would be necessary, which it's easy for us in the neuroendocrine world to say always get a second opinion. And I'm going to be the person to say that some medical decision is actually very straightforward, but getting a second opinion is, you're never going to lose anything by getting a second opinion. But when would I say, oh my gosh, I think you need a second opinion? So the key pieces of information are all, or for the most part, are going to come on your pathology report or your radiology report. But the pathology report is going to give us valuable information about the primary tumor. And in neuroendocrine, even though you may say, oh, I have an ileal, or I have it here, there, or the other way, we actually use specific terms. And it's important for you to understand the term, because if you're looking on Google, you need to be plugging in the correct terms in order to know that you're getting the correct information relative to your case. So the foregut, midgut, hindgut, and then pancreatic and bronchopulmonary are I hit maybe the most common. And I decided I wasn't going to go into the particulars of each of those today, because some of them are the rare of the rare, but I can answer questions on all of them. There are going to be other very unusual sites. So this is not a full list at all, like thymic. Thymic is one of the rarest of the rare, and can be incredibly challenging to treat. Renal neuroendocrine, another extraordinarily rare but primary neuroendocrine tumor. So I don't want to leave anyone out, because there are some unusual cases of neuroendocrine, but for the most part, the vast majority of people that are asking questions on patient support groups usually will fall into this category. So the lymph nodes and the number of positive lymph nodes over the total removed is actually an important variable when we're looking at when we would think one technique would be more or less successful. It is particularly relevant when you're thinking about the likelihood of there being residual disease after a primary tumor is removed. So that part of the pathology report becomes important. Margin status is always an independent predictor of local recurrence rate. So obviously in cancer surgery, we are trying to get to a negative margin status. And so how to address a positive margin is also an important variable to ask about. And then unifocal versus multifocal is another independent predictor of your developing additional tumors within that primary site. The differentiation status, I'll go into what that means, the Ki-67 proliferation index that also comes up on support groups, almost as if you get categorized into a box based on Ki-67, and it's a super important variable. And then obviously other histopathologic features that will weigh into certain cancer-specific risks, and that could be the vascular versus the perineural invasion. And then is the tumor got regional involvement, or is it metastatic? So regional involvement is usually within stage 3, but also can be into a stage 4 category, or metastatic, which is in the stage 4 category, and whether or not it's in a single site versus multi-site. And that's what ultimately goes into this thing at the bottom of the pathology report, of which there is T and M staging for all cancers. That remains an important variable, although we don't often talk about it in neuroendocrine as much because grade is so important, but that there's something called the AJCC staging manual, for which then most of the national guidelines are based on that. And then we are obligated as cancer people to try to explain to patients how they would fit into those guidelines. So grade. Grade is based on a couple factors. One is going to be the proliferation index, and one is going to be the differentiation status. So the Ki proliferation index, I think people are really familiar with if they are on support groups like NCAN or some of the online chat rooms. But the grade 1 up to 3%, grade 2 3 to 20, and grade 3 20 to 30, and then we pump into high grade is just trying to categorize people on the expectations of biologic behavior for any particular tumor. Where you where you can't get so hung up on grade alone is because grade for grade, a pancreatic neuroendocrine tumor may not behave the same as the same grade tumor in the small intestine. So that's why there are other factors that are really important to understand that may be weighing into whatever treatment recommendations are being made. So how I explain it to people is we're really looking under a microscope at whatever biopsy or surgical specimen that we have, and we are seeing how many of those cells are trying to divide. So normal cells will be expected to have 0 cells trying to divide, although that is not uniformly correct because there are cells in your body that divide. But that the higher the proliferation index, the more cells are trying to divide, and therefore the more they are acting like cancer cells as opposed to normal cells. The differentiation status, on the other hand, is that they're looking under the same specimen, under the microscope, and they're saying how much do they look like normal neuroendocrine, intestinal or pancreatic or bronchopulmonary? How much do they look like normal neuroendocrine cells compared to crazy cancer cells? And well differentiated means that they look more like normal cells, and therefore the biologic behavior is expected to be more like normal cells. And so, although that can be very, very good for people that suffer from carcinoid syndrome, those normal cells are spewing out then neuroendocrine hormones and proteins at higher than average rates. And so a grade 1, very slow growing, well-differentiated tumor can be extraordinarily symptomatic and still cause a lot of problems and weigh into medical decision makings, where poorly differentiated tumors are much more aggressive and often treated very similar to other types of cancers in similar sites. And I go over some examples of that. And then the lower grade well-differentiated tumors are felt to have a more predictable biologic behavior. So it's a lot easier for us to say, oh, what's your investment in whatever treatment we're discussing? Because we feel pretty good that may be the best one and done, meaning that we're going to try to eliminate this as a variable in your life, because we feel pretty confident that we understand the biologic behavior of the tumor. So let's just start with the primary tumor. So foregut includes the stomach, the duodenum, and the pancreas. And why I bolded pancreas is that I think it's kind of out of the scope. There aren't as many nuances to stomach and duodenum. They tend to for the most part, be type 1 gastrics, which are often non-invasive, associated with atrophic gastritis, rarely spread to lymph nodes, and highly unlikely to be drivers of mortality. But for anyone on this thing that has one of the less predictable gastrics, there are unpredictable gastrics as well. They usually fall into the type 3 category, and we treat those patients a lot like we treat the other type of gastric cancer. The duodenum also is usually associated with other problems of the upper digestive tract, or often managed endoscopically, but there will be occasions where higher grade tumors can behave very differently. But the pancreas is what is going to be the more common and considerably more complicated group. So I thought I'd go into more detail on pancreatic neuroendocrine tumors and unique features of that case that would drive questions about medical decision making. And then the midgut. Although the midgut includes both the jejunum and the ileum, for the most part, they lump together, even though they don't often behave exactly the same. But the vast majority of the midguts are in the ileum. So that's why we'll say, oh, mine's in the ileum. We use the term midgut in order to better understand the biologic behavior of that entire category. And then hindgut includes the appendix, colon, and rectum. So appendix has unique features. I didn't bold it, but I do go into some of the things that you need to read out on the appendix, because that's actually one of the more controversial things, even though those are probably the best acting neuroendocrine tumors for the most part. Colon is extraordinarily rare. And so that's one where I would say get a second opinion. And then the rectums often have their own nuances, can be very indolent, non-invasive. They used to be called benign, but some of the higher grade metastatic rectals can be some of the most challenging neuroendocrine tumors that we treat. And then bronchopulmonary, that we got into calling them lungnoids. I just want to make sure that we're using the medical terms so that if you're researching it, they're called bronchopulmonary, and they are usually categorized into two broad categories, typical versus atypical, based on their expectations of biologic behavior. So pancreatic neuroendocrine tumors are extraordinarily heterogeneous, and that's why there's a lot of debate and some controversy on how we manage pancreatic neuroendocrine tumors, especially metastatic pancreatic neuroendocrine tumors. And that's because the pancreas is rich in neuroendocrine cells. So you can have a insulinoma that is a non-invasive thing, but causing extraordinarily profound side effects, but that we would be using enucleation on something, whereas you could have a glucagonoma, a viapioma, a gastronoma. So there are just way too many things that we lump under this pancreatic neuroendocrine tumor umbrella. So if you have a pancreatic neuroendocrine tumor, it's actually kind of super important to better understand whether or not you fall into a particular category that would weigh into medical decision making versus it just being a non-functional pancreatic neuroendocrine tumor. But the reason why they are sort of heterogeneous in their biologic behavior is because each cell type probably does have its own nuances of how they're going to behave. So that's what makes the medical decision-making in pancreatic neuroendocrine tumors, if they are anything other than early stage and combined to the pancreas, a little bit more difficult. Functional versus non-functional, they are often non-functional and a little bit more difficult to better understand people's the symptoms they're having, because we don't have the same blood work to better explain some of those symptoms unless they are one of those categories that I just talked about. Are they confined to the pancreas versus metastatic, or are they unifocal versus multifocal? PNETs compared to other sites are often multifocal. They are particularly multifocal if they're associated with a familial disorder like NCAN 1 or 2. And so how we manage pancreatic neuroendocrine tumors is and confined to the pancreas versus metastatic is super important. That's why we are much more likely to use a PET scan regardless of what it looks like at diagnosis. Confined to the pancreas, we get a PET scan before we were to go and operate on someone with a pancreatic, just to make sure that we truly understand the extent of the disease before putting someone through an operation that has a higher than average complication rate. PNET tumors in many patients, maybe not in patients that are in an age group where it's so highly unlikely to be associated with a genetic mutation. But I think a lot of the neuroendocrine specific subspecialty programs have started to either get genetic counseling or genetic testing on most young people that get diagnosed with a pancreatic neuroendocrine tumor, because we think that probably genetic mutations are under-recognized. There are many surgical challenges associated with pancreatic neuroendocrine tumors because the pancreas is a tough organ to operate on. And then in pancreatic neuroendocrine tumors, understanding why we bring up chemotherapy in the setting of pancreatic neuroendocrine tumors, oftentimes in the setting of even lower grade tumors on occasion, is because pancreatic neuroendocrine tumor patients are more likely than other sites to actually need to have a discussion about chemotherapy sometime over their course of their disease, even if they are expected to live a long time. Midgut, though, is the common variant. And the reason why I mention that is because a lot of the data that drives medical decision makings is going to be extrapolated by what we do in midgut neuroendocrine tumors. And so when we say, oh, well, surgical cytoreduction, since we're really kind of recognized for being somewhat more assertive surgically, is that some other neuroendocrine subspecialists would say, well, hold the phone. You're trying to extrapolate something into a different setting, into a appendiceal, rectal, or whatever, when really a lot of that data is on midgut. So kind of understanding how much of the recommendation is truly based on the primary site that is relevant to your case versus us saying, well, this has been very successful, but most of the data, usually I say a lot of the data that supports this is going to be on the midgut variant, and so we're extrapolating, but the goals of treatment would be the same. They are more often functional and therefore the drivers of a lot of carcinoid syndrome and neuroendocrine syndrome type complications. And then the surgical considerations are the things that are kind of debatable, and maybe there are some philosophical differences between neuroendocrine programs because we have a lot more data to support aggressive surgical management of midguts and midgut neuroendocrine tumors. Patients can often live a very long time. And so understanding risk at different stages of what can be a 20-year process is also important, because that goes into whether or not we would be offering surgery to try to prevent something from happening. The appendix, the key things is really mostly grade or mesoappendiceal involvement. And so understanding that pathology report is really important. Oftentimes, appendix neuroendocrine tumors are picked up incidentally on appendicitis cases or cases that are being done for other reasons. For example, people getting a hysterectomy will often have an appendectomy done as part of that operation to eliminate that as a variable in future pelvic pain type things. Then you come up with a carcinoid. You're like, what the heck am I supposed to do with that piece of information? So we've appendix, even though it often is incredibly favorable, it actually is super important on what the data is now talking about in terms of the need or the recommendations on further surgical therapy and even surveillance. But that I italicized because we really no longer use, there's no magic size to appendiceal that is going to weigh into decision making anymore. Whereas previously we would look at something as being 2 centimeters or greater, and we would push towards surgery. And so we don't really use size anymore, other than anything that is less than 1 centimeter is something that is mostly wanted to me. And then rectal is very much about grade, size, and the depth, how difficult it is for an endoscopy person to get that out, and what an endoscopic ultrasound looks like for rectal. And so rectal is one of those what can be very frustrating to people that have developed locally or regional involvement from a rectal cancer, because oftentimes gastroenterologists that are not as familiar with the range of rectal neuroendocrine tumors will frankly call them benign and tell patients that nothing needs to be done. And I'm here to tell you that the vast majority of times that is a true statement. We don't use the word benign anymore. We use the word non-invasive because there are going to be cases where there will be local regional recurrence or additional rectal tumors that develop within the rectum that the surveillance is necessary. And definitely I want people plugged into our program, regardless of whether or not I'm giving good news or telling them that they may not need me long term. But I think it's just really important to better understand which patients actually need longer term surveillance with rectal. The bronchopulmonary are, as I said before, typical versus atypical. The typicals are the low grade, well differentiated. They tend to be confined to the bronchus of the lung. They are often non-invasive, very rarely spread to local regional lymph nodes, are unlikely to metastasize, but are often associated with respiratory symptoms or overlap with respiratory symptoms like asthma, bronchitis, cough, things like that. And so medical decision makings in bronchopulmonary, when they are typical, will often be based on symptoms. The atypicals are the ones that are somewhat higher grade or have histopathologic features that would suggest that they may not be as predictable biologically. They are more likely to be node positive, more likely to metastasize to different sites. And so we will often treat an atypical carcinoid probably a little bit differently, or at least give recommendations on surveillance a little bit differently, because the cancer specific risks are different. That bronchopulmonary carcinoids, in particular, the typicals, can actually be more likely to be multifocal. So you can't start going in and doing Swiss cheese in the lung, taking out a bunch of multifocal typical carcinoid tumors that are unlikely to be drivers of mortality, but that those patients are obviously surveyed long term. Metastatic bronchopulmonary can be some of the most challenging patients that we treat, because the biologic behavior can be somewhat more aggressive than the ones we're typical for the abdomen. And then we will not often use somatostatin receptor analogs unless someone seems to be symptomatic with a neuroendocrine syndrome. There's just less data to support them, but it doesn't mean that there aren't particular cases where we do. And so then what's important to better understand before you're certainly making a decision about surgical intervention is, do I have regional versus metastatic? And so regional involvement means that you have the primary site. It can be universal. It can be unifocal versus multifocal, and you have lymph node involvement. So that is something that is still considered a surgically curative problem, and I'll go into what that means. And so regional involvement means, can I get this entire bulk of the disease out, just like I would if this was breast cancer, local regional involvement, or colon cancer, local regional. The idea is the question is, can I remove all measurable disease? Because then you're unlikely then in the short term to need any adjuvant therapy, even SSRI. And so determining whether or not something is regional involvement versus metastatic is super important. Now, regional involvement into a nodal basin that is beyond that which is within the mesentery itself, for example, in the midguts or outside the peripancreatic region, within the AJCC staging system, you're going to get to an extent of lymph node involvement that would actually be equivalent to metastatic disease. So that's another important thing to know. And then the metastatic would be important on where is it metastatic, since we very much concentrate on the liver. It's really important that we concentrate on the liver because neuroendocrine specific mortality is often because we can't control the liver. And so is it liver only versus liver dominant? Because that may weigh into how we make the decisions. Or do I have multi-organ site? Because that's where much of the conversation about PRRT comes into play. So the surgical considerations, just because I'm a surgeon, are that we need to understand whether or not the operation is being done with curative intent, palliative intent, or what we call surgical cytoreduction. And all of those just have somewhat different nuances that will go along with questions that you should ask. And then, are you doing a primary resection, and what does that entail versus a primary section plus a metastatic disease, or are you going just into manage metastatic disease? So the definitions that we use in medicine, although we will rarely actually use these terms in non-neuroendocrine cancers all the time, but for some reason we just don't seem to use these terms even at national meetings, because there is so much risk over a really long period of time of a recurrence, either local recurrence or the development of metastatic disease, even in really slow-growing neuroendocrine tumors. And so we don't often, speak with as much confidence that we won't be having a conversation about recurrence in neuroendocrine as we would 5 years out from a colon cancer case where we were like, I think you're cured. So when a procedure is being done for curative intent, it means that we're giving you every opportunity to be quote unquote cured, meaning we are eliminating this as a variable or a driver of your mortality now. And that's a cancer term, and it is relevant to any cancer that you would have. And so if I am having a conversation with someone and saying, hey, if you only have local regional involvement, we have a PET scan suggesting that it's only within the small bowel and the lymph node basins, then removing all measurable disease, we're trying to put you in approximately 40% chance of not experiencing a neuroendocrine specific event over the course of your remaining lifetime. And so then, we continue to follow you, and the guidelines are up to 10 years of follow-up. And then as you tick on in those years, really, it's not that you are completely eliminating your risk of recurrence, because all of us in neuroendocrine specific programs have seen recurrences even 15 years after the thing. So people in support groups will say, oh my God, he told me that I was cured and now I've got metastatic disease. What the hell does that mean? But the fact is that your risk does go down over time. I just say, hey, you're just like setting up a lawn chair in the 40% likelihood of not having a neuroendocrine specific event. We still will survey people long term. And I tell young people in particular, like 40, 45-year-old people with a lot of life years ahead of you, that there's no magic 10 years you get to ring a bell and you fall off our radar. We continue to honestly follow people until they have clear other drivers of mortality. For example, if I have an older person and they call me and say, I just had a heart attack, we're like, okay, hold the phone. We're gonna focus on the heart now, and then we'll come back in and see whether or not ongoing surveillance for neuroendocrine is even necessary. So things that are done with palliative intent is also really important in neuroendocrine. We do a lot of operations with palliative intent. We just have to understand what it is we're trying to alleviate. So that means that the procedure is meant to alleviate some sort of a symptom or to try to prevent a likely complication if a surgery was not performed. So if someone has a lot of symptoms of carcinoid syndrome, then we will do often very aggressive surgery, surgical cytoreduction. And if we meet the goal of treatment, which is to alleviate a symptom, obstruction, perforation, bleeding, carcinoid syndrome, whatever it is, then we've met that treatment goal. And it doesn't mean that surgeries done with palliative intent do not prolong life. It's just that that's not the goal of the surgery. And so if someone says, "Oh, I'm going to do an operation, and I'm not going to cure you," you're like, "Well, we don't do a palliative operation to palliate the fact that you've got cancer. You have to actually define what it is you're trying to palliate, so you hold yourself accountable for having reached that treatment goal." So it's not, the success of the treatment is just not measured in quantity, but in quality of life and alleviation of that symptom. And then surgeries in cancer are often done with prolongation of life. So when successful, the procedure is associated with a longer expectation of survival compared to no procedure or medical therapy alone. So someone would say regular old pancreatic cancer, there's a very poor overall prognosis, but it doesn't mean we don't operate on pancreatic cancer, and we don't use the word, "I'm going to try to eliminate this as a variable in your life." But the reality is that even early stage pancreatic cancer can come back and kill someone. But it doesn't mean that we don't give them every opportunity. And the patients that have an operation do live longer than patients that are considered unresectable. So those are operations being done with prolongation of life, regardless of whether or not the biologic behavior of the tumor on pathologic features is more aggressive and requires not only follow-up, but additional treatment like chemotherapy. So surgery done with curative intent is just, this is just a little cheat sheet, means that midgut, you're taking out the small bowel with the mesenteric lymph node dissection, the pancreas with pancreatic lymph node dissection, the lung plus or minus lymph node involvement. So you are documenting on that TNM, you're documenting that you have removed not only the primary tumor, but the draining lymph node basin, so that you can adequately stage the patient as an early stage patient for which you have removed all measurable disease. And then it can be used in certain circumstances. That's why it's really important to know your case, limited, where you are taking out all measurable metastatic disease, like a deeper lymph node basin, or a single site in the liver, because there will be unusual cases where that is the only site, and that by moving all measurable disease, you eliminate or diminish the need for additional treatment. And then surgery done with palliative intent. These are just some examples of that, so that you would better understand, like, what are the types of things you would do. So removing enough tumor burden to decrease symptoms of carcinoid syndrome by removing the bulk of disease within the liver on a metastatic midgut primary. That is probably an operation that we do commonly. Now, there are other treatments that are not part of this talk that can also achieve that goal. So it's really important to understand those options. And then removing tumors where the location is associated with pain. So alleviating pain is a big indication. Tumors causing obstruction, that's obviously, we need to relieve the obstructions, and tumor causing bleeding, we need to clean the bleeding, or else we won't be able to manage it long term. And then the prolongation of life is when we talk about surgical cytoreduction at both patient support meetings as well as our national conferences, where we all agree that there's going to be no magic number. It's not 70%, it's not 50%, it's not 90%. It's that we need to remove a critical mass of the tumor burden in a particular patient to feel that we have changed the course of the disease. Where had we not done it, they would have not lived as long. So when to consider a second opinion? It's really so easy to say, always consider a second opinion. I do say that in rare cancer diagnoses, getting a second opinion, if for no other reason to hear the same words out of another person's mouth. It's just reassuring that the opinions that you're getting are like sit right with the medical decisions that you're making. I just had a second opinion on a patient where they were confused on why one person had said one thing and another person had said a slightly different thing. And the fact is that both opinions were correct. They just hadn't gone into some of the particulars about her case that would actually make both those opinions reasonable. So then we had to get into the head of the patient on how they make decisions and how that decision sits right with that individual patient at that stage of their life. So if the treatment options and alternatives are not clearly described. So I think it's super important that most neuroendocrine specific programs and most major cancer centers work in multidisciplinary teams where even if you're hearing the words out of one person's mouth, those words are supposed to represent the philosophy of the team. Now, if someone on that team is not going into all of the treatment options that are available so that you can put them in perspective and put into perspective what you're reading on the internet, well, then you need to get a second opinion because you may then get maybe some advice from someone you're saying, God, they didn't even mention that. So I will often tell people, I'm going to go into all of the options so you can better understand all the things that are in our bag of tricks. But I'm going to go over why one is more or less relevant for you right now. Because in neuroendocrine, because patients can live a long time, we often have to go to the same menu. I keep going back and saying, okay, we're going to open up the menu again. And we're going to say, why is this option really quite good for you now? Like PRRT, even though I told you that we were going to choose door number 1 when we started. And so I like people to understand all of the alternatives so they can put in perspective how that relates to not only their case, but the way they make decisions in their life. That is the definition of informed consent. So before you go into an operation, the whole idea is we're supposed to tell you what the alternatives are and what would be expected if you were to take that alternative versus the one that you're taking. So when options seem limited, so neuroendocrine is all about options and it's all about leaving options open and choosing an option that is most appropriate for a person at that particular time with that disease burden. So if you're finding you're saying, wait a second, that I'm usually thinking there are a lot of options here, even if there is that, and you're giving me one option. You're saying, okay, we need to do surgery, or we need to do this, or you're surgically unresectable, or whatever. You're saying, wow, it's like there are no other options. Get a second opinion, because sometimes the options are really in the eyes of the people that are giving you that opinion, or maybe some of the inherent biases that we all have on how we're interpreting the published evidence. Mixed messages. A lot of people online will talk about, hey, I feel like I'm getting mixed messages. Like I'm not sure there's agreement in my case, or they keep coming back, or someone said one thing and then they took it to tumor board and now they're coming back and they're saying something else. Get a second opinion. Oftentimes, the second opinion can even explain maybe some of the mixed messages that you get without it seeming like you are part of the mixed messages, because you're kind of a third, objective party. Some people will say, I just felt like I was rushed. I felt like I had a lot of unanswered questions, so that it wasn't really that they were not giving you a perfectly fine opinion, but that you felt like you didn't have enough time, or you weren't able to digest all the information that was coming out in that meeting, and you just feel like there are unanswered questions. Then you can either go back to the same person. Say you got an awesome vibe from the person. You say, no, can I just get a second a second appointment so that I can just go over some of the unanswered questions? Neuroendocrine is one of those things where I think that there's enough challenges in how we make decisions, because there's so many unique variables patient to patient. is that sometimes you just won't fit into the box. And so just making sure that you get all of your questions asked before you make a decision. And honestly, I usually just say, even it's for peace of mind for you or your loved ones, to know that someone is saying the same thing as the next guy. Some cases are extraordinarily straightforward. And I will tell people online that want a second opinion, I say, hey, you know what, we can do this both either way. I can either start from the beginning and you can hear my whole spiel, or we can just focus on the things that you felt weren't answered, or particular things that you want to go over. Usually they say they want me to start from the beginning and just go over so they can hear it again. But then sometimes people say, well, no, this is what I just need my peace of mind that this is it. And I'd be like, yep, I'm going to tell you this is a super straightforward case, and that's an action. That's exactly what you would hear out of my my mouth, and just the peace of mind factor is this. And then I think that my advice. That is treatment plans for NET need multidisciplinary input. Oh my gosh, Mary Ann Wallman will like beat that into your head at our patient meetings and online, is that the one thing that we have for those of us that live and breathe in neuroendocrine is when neuroendocrine opinions are not actually including all of the treatment options because they don't have all the people at the table. So that includes a lot of disciplines that may or may not actually be part of normal tumor boards. For example, interventional radiology. You can't do neuroendocrine without interventional radiology. I personally think that you also need radiation oncology. You need nuclear medicine from a PRT. So you need all the elements in order to get a robust opinion. You also need them to have a tumor board with a tumor board summary so that you can understand exactly who is at the table. And so therefore you feel like you're getting a balanced opinion. And then this is just my shtick. This is one where I'm going to say this is, I'm talking my own opinion, not necessarily the opinion of very smart neuroendocrine people. But I just think that if there's a question of whether or not surgical intervention is appropriate or inappropriate, I think there will often be some frustration when a medical a subspecialist is telling someone that they're surgically unresectable. I do think that as part of a multidisciplinary program, even if you're giving an opinion that surgery is not appropriate at that juncture, I think that the surgeon needs to step up and have that conversation with someone if they have further questions about that, rather than relying on the medical professional. But I want to reassure a lot of you that tumor board is about those discussions. So it's not that a surgeon did not give that opinion, but that I do believe that if a patient has particular questions about surgical intervention, that should come out of the mouth of a surgeon, as opposed to a nuclear medicine or radiation oncologist or medical oncologist. And then none of the things that we use in neuroendocrine are usually mutually exclusive. We can use them alone or in combination. And so there are definitely some programs out there that will use surgery plus liver-directed therapies, or liver-directed therapies along with PRT. And so I don't want you thinking that once you're on one path, there's no other path. And then treatment has to be used judiciously. Oftentimes people will live a long time, so you don't want to start to have it be a trade-off of one problem, the neuroendocrine that you have, for another problem, which is all the complications of the treatment. And the whole goal for all of us is to keep treatment options open. Don't hesitate to ask questions, copy, and then keep copies of your records. So I think it can be very burdensome for both the patient and the programs to have to try to track down records that are from 10 years ago. So for those of us in the southern region, people's records were completely destroyed during Katrina, and so it's just being your own advocate is also making sure that you have copies of all of the pertinent records, of which obviously the pathology, the operative reports, the imaging, and some of the clinic notes are so important. I don't think we need your vitals for every visit or some of the hospital records, but I'm telling you that you don't need the whole book of the tome over 15 years of a disease. But I think some of the really critical things that are important in medical decision making are very important. And then this is where we're always available. And I reassure everyone of these things is that the neuroendocrine community gets along extraordinarily well. We are collaborative, not competitive. We are just trying to make a difference in neuroendocrine. So where I feel like I am truly obligated to focus on the southern region, I have great admiration and respect for John Strasberg, who has the entire state of Florida, or the people at MD Anderson that have their own value. But that at the end of the day, we reach out and we talk to each other. We are all extraordinarily collaborative. But at the same time, we've all made ourselves really available over the phone, by email, and then there are a number of these types of presentations. There are patient conference presentations, but there are also like Carcinoma Cancer Foundation type videos. And so there are a lot of organizations that want to get the information out there, and you can hear me give a talk about surgery, and you could probably find through these other organizations Jim Howe giving a talk on surgery, or Pommier giving a talk on surgery. But I did have this. This is just a QRL code for some of the Carcinoma Cancer Foundation videos that we have done. There are also some Facebook Live videos that we've done that also come with a QR code. So anyone that wants that can just reach out to me. So that's it.
Well, thanks, Dr. Maluccio. That was really awesome. It created quite a few questions. Just so you can see them. Audience, if you have questions, hopefully you know how to access the chat function, which at the bottom of your screen, you should see a little black bar across there. It says chat, share screen, breakout rooms, things like that. So you can access the chat by hitting that button if you have questions. Looks like starting at 10:28 of the session is when the first questions come through.
Okay. Yeah. So do you want me to just go over those? Okay. So wow, yeah, you guys definitely went into the nitty-gritty of things. Okay. So I am so I got into to neuroendocrine because we ran a really broad transplant program, and we're probably the center of excellence for transplant in neuroendocrine. So I am still the person that gives most of the opinions when it comes to transplant, either single organ transplant or multivisceral organ transplant for neuroendocrine. And I still have really strong relationships with programs that do transplant for neuroendocrine. So I can always give that talk. That's just a totally different talk. That's my surgery talk. Now, the practice of using the octreotide protocol. So that's actually, and I wouldn't necessarily say it is debatable or controversial. I think most, if not all of us, have some protocol that we use both for interventional radiology procedures and for surgery. But I also want to recognize the fact that there are groups that are trying to study this and figure out what about this protocol is actually important or less important. So Pommier did publish actually a pretty strong protocol that was convincing that perhaps it's not the octreotide that is the answer to that, and that there's probably more factors that go into carcinoid crisis and the way that we would manage it. So my opinion on that is that the protocol is not just about octreotide. I think that what the question that Pommier was trying to ask in that paper that he published was whether or not us just pushing a lot of octreotide is going to get someone out of a carcinoid event intraoperatively or during a procedure versus anything else. And I think that he pretty much said that it was no different than trying to push anything else. Sorry, Dr.
Maluccio. For the benefit of the audience, maybe some of them don't know what the octreotide protocol is.
Got it. Okay. So the octreotide. So for patients. So we use for patients that have an elevated serotonin level or signs and symptoms of a neuroendocrine syndrome. It's actually super important that anyone that is taking care of you. I actually tell people that it's probably wise to have a medical alert bracelet, because those patients are managed somewhat different. Even if you get in a car accident and you're in a trauma, they have to recognize the fact that you may or may not have the same reaction to that trauma or to the medicines that we will usually use under dire circumstances. So most neuroendocrine patients that are symptomatic or functional are on some sort of an octreotide analog, so either LAR, sandostatin, or lanreotide, and all that is trying to suppress then the signaling of those cells under stress. Now, an octreotide protocol, on the other hand, is when we are using octreotide plus or minus, which is usually plus, other medications that are trying to blunt that reaction to that stressful event. And so the octreotide protocol that we use is a combination of short-acting octreotide given as an intravenous, hydrocortisone, Zofran, and Benadryl, and a histamine blocker. And all we're trying to do is try to blunt the manifestation of many stressful things that will feed into someone having a worse neuroendocrine syndromic event. And so the controversy was whether or not the high doses of octreotide that were being touted as part of that protocol were necessary. And so I don't think that octreotide is going to be the deal maker, the deal breaker. I think what we all agree on is that patients that are syndromic with a neuroendocrine syndrome and elevated serotonin levels can have a paradoxical reaction to epinephrine. And so epinephrine, when used under dire circumstances, is one of the many things that anesthesiologists or EMS personnel would use under those circumstances, but it's not the only thing to have in their armamentarium. But that obviously, EpiPens or something like that, is that you just may not get the same thing. And in general, sometimes it can actually exacerbate the very problem that you're trying to alleviate. So the understanding of the signs and symptoms of carcinoid crisis is not going to be something that even EMS or anesthesiologists that are not familiar with neuroendocrine are going to be familiar with. And so it's kind of important to know that those protocols exist, and we send those protocols to many anesthesiologists across the board. So now epinephrine, when it's used along with lidocaine for dental procedures, that's not what I'm talking about. So I've had a lot of phone calls, angry phone calls from dentists that are saying that the patients are refusing to get epinephrine. No. Having a dental procedure where you are not keeping that local anesthetic, that's just about keeping the local anesthetic in that area using epinephrine. That is not a systemic dose of epinephrine, and that is not the circumstances that we're talking about.
Well, that's interesting. I know that we've been doing this for years, and that is a misunderstanding that I had.
Yes, and so we do. So Gene Waltering would put it on as an allergy, and I would get caught out on that in a number of panel discussions. But I think that his point was that I think it's really important that people understand a patient is a neuroendocrine patient, even if they are I don't know, walking in the door and delivering a baby, or having an appendectomy, normal appendectomy, or a gastric bypass, whatever it is. You need to understand the physiology of a neuroendocrine patient can be very complicated, and you have to read the signs a little bit differently. And so I think that the only way that we can do that is to put it on as an alert. And then the alert comes under this allergy tab. So then people get, it just sort of gets out of, it goes out of proportion to what the reality of the situation is. But then trying to explain it in the setting of each individual patient is also incredibly difficult. So it is one of those things where now I code it a little bit differently, but we are also getting better at that, just from a medical professional standpoint with the EMR, where you are actually defining the reaction to the medication, as opposed to calling everything an allergy, as if you're going to have an anaphylactic reaction to something, which is not the case.
Wow. I think at this point, what I'll do is I'll kind of ask the question to you, and that's just for clarity. We are recording this so that people who can't read the chat are able to understand what the questions are. So the next one that I see is question that says, seems to be a lot of newly diagnosed gastric nets whose pathology reports don't address the type of gastric net. Is that implied in the stage or grade?
Yeah, that's actually an incredibly great question. That's why I prefer to give an opinion on gastric nets. So the vast majority of gastric nets are type 1, and they are not part of the pathology report because the pathologist actually is not typing the thing. But so, for example, someone will say, no, I had a grade 2. And I'm like, no, you had a grade 2 type 1, or you had a type 3 grade 2. So it can make those reports even more confusing. So type 1 gastric carcinoids are often associated with atrophic gastritis, which is an autoimmune disorder. And that's going to be associated with other blood work abnormalities that are driving the development of those tumors. And if we understand what's driving the development of those tumors, we understand the biologic behavior of those tumors. So the fact that we operate on type 3s and rarely operate on type 1s, oh yeah, we need to know what the type is. So there is, if you were to type in, say, hey, for example, I have someone said I have a gastric carcinoid, and you would say gastric carcinoid, and it's going to then come up as the types. So type 1, which is often associated with hypergastrin states. So that can be either atrophic gastritis, which causes hypergastrinemia, which is just one of the checks and balances of that part of the intestinal tract. But it can also be associated with proton pump inhibitor use. So proton pump inhibitor use alters the checks and balances of the stomach as it's communicating with the duodenum. It is revolutionized hyperacid states, gastroesophageal reflux disease, peptic ulcer disease, and things like that, which is awesome. And those things can kill you. So understanding that the side effects, if you were to read all the small print on that pantoprazole or omeprazole prescription that you have, the development of carcinoid tumors is on there. But the tumors that develop under those circumstances are usually the non-invasive, rarely spread to distant sites. And so there are times when I'll say, gosh, do we really need to be on the PPI, or could I take you off the PPI and then rescope? But I have many patients with type 1 gastric carcinoids that can't live without their PPIs. So all it is just a better understanding of the biologic behavior. Type 2s are the ones that are associated with familial disorders or genetic mutations. And so therefore they are more often to be multifocal. And so those people have to be surveyed somewhat differently, because you won't have gastrin to follow and you won't have an explanation for it. And so therefore the biologic behavior may not be as certain. And then type 3 are the ones that we don't know why you got it. They aren't associated with gastrin. And so therefore they are, by all intents and purposes, a cancer. Now, they are treated very similar to the way that we treat regular gastric cancer, meaning that we resect them surgically. But I don't want anyone leaving here thinking that they are necessarily bad. Is that they are, in general, the prognosis is considerably better than the garden variety adenocarcinomas of the stomach, but that they also can be higher grade. They usually present with larger tumors. They are often presenting as bleeding tumors. And so the risks associated with the type 3 gastric carcinoid are very much going to be related to the pathology report on all the grade and the proliferation index and things like that.
Wow. Okay. Terrific. Now, the next question, which I think you're scanning, hopefully, because the way I read it is it's ovarian cancer versus a diagnosis of neuroendocrine cancer of the ovaries. And how do we explain that?
Yeah, so that's actually something that's been going on one of the chat rooms, and then I tried to explain it's a super complicated situation. And so if it's the same person, I told them to just call me and that we would probably have to have a larger conversation. So I think that, so peritoneal carcinomatosis and the way that we use those terms it can be vastly different. So if you start looking on the internet under carcinomatosis, that it's not that is completely irrelevant to you in the neuroendocrine realm, but carcinomatosis that comes from an adenocarcinoma like appendiceal, colon, or something like that, versus a carcinomatosis that comes from an ovarian primary, totally different, versus a carcinomatosis that comes from neuroendocrine that can end up being a low-grade histopathologic variant, are three vastly different conditions. So what I was trying to explain, if this is what I was trying to explain on the internet, is that the diagnosis of a peritoneal carcinoma yes, which they believe is actually an ovarian cancer that spreads through the peritoneum. We call it, it's like the molting of a bird or the snake, sloughing its thing, and it sloughs off, and the cells actually swim within the peritoneum and latch on, to organs. That is very typical of an advanced stage ovarian, but that a lot of cancer subtypes, colon cancer can have a subtype that has neuroendocrine features. Ovarian can have a subtype that has neuroendocrine features. So it's not that means that it's not neuroendocrine. It just means that we have to look at it like it's an ovarian with these weird features and not a neuroendocrine of the ovary. There are extraordinarily rare circumstances where a neuroendocrine tumor originates in the ovary, but that's where, oh my gosh, there are so many more variables on the pathology report that become important because they do a bunch of these stains. We call those IHC stains. So you have the CDs, the SR4s, the ML1s, and all TTFs, all these things that are trying to explain to us whether or not we believe that this is going to be a primary ovary that is spread this way, or is it a primary neuroendocrine of the ovary that is spread this way? Is it the neuroendocrine that we're worried about, or is it the serous ovarian adenocarcinoma that we are worried about? And then if there are any questions in our mind that we are truly a little bit confused on what's going on, now we have what's called genomic testing. So it's kind of genetic testing, but we use the word genetic testing when we're testing a patient, and we use genomic testing when we're sending it to those tech companies that literally test the genetics of the tumor, looking for mutations. We will send it for Caris or Foundation One or Tempest testing to determine whether or not there's something about that would clarify that situation. So anyone that has carcinomatosis and they aren't clear on what is being told to them, definitely a second opinion is super important. And I think that trying to figure that out on some of the patient portals is that is like, that's like taking the econ class your senior year of college compared to taking like Econ 1, where we're just looking at supply and demand. So I think that carcinomatosis is an entirely different beast, and one that would require a very unique conversation about what we think is going on.
Not something necessarily in a support group that you'd get any kind of.
No, yes,
technical.
it was, and it's so hard to give advice. There's just so much more that you aren't going to be spelling out, the whole pathology report, like, oh, here's my pathology report. It was one of those things that I think was going to require a very in-depth conversation. Now, this could not be the thing that I was commenting on online either, but that situation, and when you're talking, even using the word carcinomatosis means very different things when you're looking at it in the context of a grade 1 mid-gut neuroendocrine tumor versus in the context of a higher grade appendiceal, but they're all called the same thing. That's why those words that we're plugging in to try to get that information are so important, and why I think it sows confusion in the patients, because they're like, oh my God, it's all over the board. And I was like, well, it's all over the board because we haven't actually honed it into that which is most relevant to this situation.
Oh, okay. Very good. Very good. Next question is, this is interesting. Access to a system's EMR equivalent to collecting copies of records.
Yeah, and it is changing the face of what it is we do, other than maybe hacking. I don't know, maybe I'm not a cryptocurrency someone, so I'm just like, oh my God, it all is like scary to me. So I think that the fact that I have had patients literally open up something from an entirely different system that I didn't have access to and hand it to me on their phone and be able to give me all that information. It is amazing to be able to have that at your fingertips. Now, for some of the people that don't have as good sort of access infrastructure, so a lot of our patients in the South that may not be able to do that. But yeah, when I say having your records, having your access to your records is the same thing as actually having the paper copy records. And in all honesty, is probably even better. You would not be able to organize it quite as much as you would be able to in a binder, say, oh, you're looking for pathology, but I'm telling you, those apps are getting more and more sophisticated in your ability to open up different features of it. And that's exactly the same as having copies of your printed records.
That's amazing. Yes.
Bob, I'm just going to interrupt really quickly. Yes, the records are very, very important. I just started a clinical trial and, having this disease for 21 years, my oncologist didn't have any records that are on the computer. They're all in boxes in different storage areas. And it became a problem because I was missing one of the tests and I happened to find it to get onto the clinical trial. But it is really important to make sure that you're getting onto these systems to get your records. And if you can keep copies of it, that's great. If you can't, at least have access to it.
Yeah, for sure. Dr. Maluccio, how are you set for time? I know we're running a bit over.
Oh no, I'm perfectly fine. Bob, it's Saturday.
Okay, sounds good. Now you didn't really mention biomarkers as key information. Is that can you elaborate on that?
Yeah. So I'm huge into biomarkers. They are just not as well established as you would think they are at giving us the information that we need. So if we talk about the established biomarkers that we would use for like serologic. So those are the blood tests that you always hear about: chromogranin, serotonin, pancreastatin, neurokinin, ghrelin, all those things. Is that those across the board are not necessarily relevant. And so that's some of the things we debate at our national meeting. It does not mean that they are irrelevant in particular cases. And some of them are actually incredibly valuable in some of the most common patients, like the mid-gut primaries. Now, biomarkers are evolving. So both our program and Iowa are really strong into trying to understand either unique biomarkers or biomarkers that we used in common. Now, I will tell you that I'm particularly interested in using them as a surrogate for response to treatment, because oftentimes our imaging does not actually tell us the whole picture. But the biomarkers that we currently have are actually more about prognosticating, which is really kind of just doing a lot of work to tell someone that it's to try to tell someone that it's worse than we thought it was. And rarely am I saying, oh, Ray, you have the biomarker that says that, you're home free. So most of the things we're looking at in terms of biomarker, either the current ones that we use or the ones that we're trying to look at, are most often looking at prognosticators, but those are also important because we may then have to start to focus clinical trials or treatment or surveillance differently for the 10, 15, 20% of people that may have biomarkers that would suggest that they aren't going to fit into the standard care. The biomarkers as responses to treatment, I personally think, are extraordinarily important, especially if we move away from things that are readily accessible on imaging. If you do an operation on someone, that tumor was there, and then you removed it, and then you get follow-up imaging, and it is no longer there. So that if you have someone that has an operation, you remove everything, and then on another scan, you all of a sudden have stuff there. That is progression. So you don't need some biomarker to tell you that situation because you know the situation. But for a lot of the other stuff that we do, whether or not it be chemotherapy, PRRT, somatostatin receptor analog, oftentimes we're looking at those imaging and we're like, okay, everything looks good. It all looks the same. Nothing's changed. Almost like we're waiting for the fork in the road to tell you, okay, things have changed. And so we don't have anything that would suggest who absolutely needs to be on SSRI 20 years after a low-grade mid-gut, regardless of whether or not they have measurable disease. We have no idea whether or not people need 4 doses of PRRT or 2 would be okay, or who benefits from the 2 additional doses of PRRT. So there's a lot of stuff that we do that's done all for the right reasons, but we don't have good markers on or additional information that would be able to tell a person whether or not investment in one thing or another would be worth it for them in that case. So now that's a biomarker question is super broad, but the current biomarkers we have are predominantly prognosticators, but it doesn't mean that they don't show us a response to treatment, because you can definitely see a diminishing in serotonin or pancreastatin after treatment of a particularly intestinal neuroendocrine tumors. And then some of the other biomarkers that are evolving or being used in other sites are often more prognosticators and not so much response to treatment biomarkers. And then the biomarkers that are coming down the pike are trying to figure out whether or not someone would or would not respond to something if we knew this biomarker up front. Are they responding or not responding to what it is we're doing, regardless of what the imaging is showing, or would they be appropriate candidates for a certain clinical trial?
Okay, next we have a patient with an unknown primary. I don't think you really discussed that. Is that a special issue when you're treating a patient?
Wait, I'm sorry. Were you? I was reading this question and then listening to you, and I don't think that you were asking me the same question as I was reading. What was the question?
It's a question about an unknown primary, and wondering if there are special issues that could be discussed.
Yeah, there are. So I would say that it's actually extraordinarily frustrating for both the doctor and the patient when we have something that's pulled out of a metastatic site and we aren't able to categorize it, and therefore we don't have the ability to say, okay, this is the natural history, this is what we would expect with this entity. That's why neuroendocrines of unknown primary have very unpredictable biologic behavior, but it doesn't mean it's necessarily unpredictable, because had we known it was in the pancreas, we'd be like, oh yeah, this is totally predictable. If we knew it was in the lung, it would be predictable. So then going back and overlapping with the biomarker question, we are one of the biomarker discovery type of things that we are doing that other people have also tried to do, is just to better understand that unknown primary and how we would try to categorize it based on certain, we're using metabolic features. And there are tests that you can do to try to say, okay, we don't have any idea where the primary is, but the metastatic disease is hot on PET. We just don't have any PET activity elsewhere. So we will usually, based on the pathology of that metastatic site, say that if it has these pathologic features, meaning grade 1 or well differentiated, well, we could probably put our money down just on the odds of it being hidden somewhere in the intestine, because you got a lot of intestine, and it's hard to survey the intestine. But that the other sites have not actually been as well characterized on those biomarkers. So you can have something they say, oh, I think it's 90% going to be in the belly compared to the lung. Well, that doesn't really help us too much on what it is, because the belly is a whole lot of sites. And if they say, oh, I think it's predominantly in the lung, well, if you are finding it in a metastatic site, then by nature it's going to be atypical. And then all bets are off on the biologic behavior, and we'd have to go based on somatostatin receptor avidity and things like that. So neuroendocrine tumors of unknown primary can be extraordinarily challenging and very frustrating. And I tell people that they are probably more likely than not going to have ongoing discussions about treatment options compared to your being able to settle someone into an expectation of what the next 5 years looks like if someone has the primary is known, just based on the fact that we can fit it into an algorithm that is pretty well tested. So yeah, we do a lot of testing. We try to do anything we can to try to say, hey, what do we think it is going to be? But sometimes you just don't know, and it can be very frustrating.
Yeah. The next question is regarding insurance. How does insurance considerations enter into the decision tree? Because you get a second opinion, and insurance is likely to reject that.
Yeah. So that's that's actually kind of an interesting question. Like, it's a good question, but it's interesting. And so I think that insurance companies have medical policies. Those medical policies are going to be a certain degree of separation from what we call CMS, which is going to be the Center for Medicare and Medicaid Services. And so the issue that rare cancer patients have is that oftentimes the heterogeneity and the rarity of the tumor doesn't fit into the medical policy. So therefore, you have to make an argument. I have to explain in great detail why X, Y, or Z is necessary. And that's where a center of excellence has less problems getting something approved than a non-center of excellence. If you're getting treated at a regional cancer center that is not known for that, or the pathology is not read in a certain way, or you can't document it, or the doctor, you read some of those notes. I'm telling you, I've read some notes and you're like, well, I'm not sure I would have approved it either. They didn't really go into detail because doctors, especially of the yesteryear, are used to saying, you know what, I'm the doctor, I'm telling you I need it. And you're making me like beg for it. But that I will tell you that we don't have as much problem. Like, I can tell a patient when I know that I'm going to have trouble getting something approved, but it's usually because I want it, but don't necessarily need it. And therefore I'm trying to make an argument for it. But I have had innumerable patients that have had things rejected from the insurance company for no other reason than the documentation wasn't there. So then you have to say, well, if they don't put in the documentation, you're giving the insurance company the ability to say no. And then the second opinion on this, I'm not sure there have to be CMS rules on the coverage of a second opinion for something that doesn't have standards of care. So that is a great question that I haven't been asked, but I bet that there is a policy on the ability to get a second opinion. I don't think they can deny you a second opinion. They're going to deny you a scan. They can deny that. And often that's just about documentation. And in all honesty, we're all stressed out in the medical profession. And oftentimes, say, for example, a gastroenterologist, they just don't have the bandwidth or the people in their office that would be able to do the peer-to-peer, or they don't want to be bothered, or that they just don't have the time. But that if you're getting a scan rejected and you don't understand why, and people are saying, I should be able to get the scan and I'm just going to give up because is that I think it's going to be because it's not being documented properly, or it's something that they haven't fit into the medical policy. But that a lot of us live in the world of neuroendocrine, really understand the medical policies for most things, that we certainly understand the medical policies for things like, Medicare, Blue Cross Blue Shield, United, all the major things. Where we have run into trouble is with the exchange network, where people were, whether or not we believe in being required or just trying to get coverage, is a little bit like buying the car insurance coverage. Like, if you get an offender mender, you're not covered, but it's almost catastrophic. Well, you get a policy that's just trying to cover you for horrible things happening to you. And then that policy will not cover something like this. And that's problematic, but that's what, resources are for, to try to find workarounds for that. So we have had some difficulties when people have some of those really basic policies where you're actually signing on the dotted line saying, I realize that this is not a comprehensive policy, but that you didn't expect to get a neuroendocrine tumor. So what could you do about it? So we try to have workarounds for that. But if you're having trouble getting something, and that usually it's going to be a documentation.
Just got to keep working on it when it comes to insurance. That's for sure.
Yeah.
So looks like a follow-up to the epi question, a pancreatic net who has all kinds of symptoms, rapid heartbeat, sweaty, turns bright red. And I guess she's wondering if maybe she's just epi sensitive and that it doesn't have anything to do with the net. And I think that would be with dentists and things.
Oh, yeah, sure. So you can, under stressful circumstances, so they say, for example, let's just look at epinephrine. So your fight-flight response is going to be different in almost any person. So you can even tell, like in people that are public speaking, you can tell when someone is having a all over body reaction because they have some sense of nervousness because they are in a position for which they are uncomfortable. You can see it. They get red in the face. You're like, oh my God, they look like they're having a lupus or carcinoid. Is that they will get red in the face. So the manifestation of many, stressors can be different. And that's why people say, God, my serotonin is not even that high. And I am like Rudolph the Red-Nosed Reindeer. And someone say, oh my God, mine's really high. And I don't have any of that. That's just going to be unique to the physiology of that patient. Now, the reaction to things like an EpiPen or epinephrine or things like that can also give you the same reactions. That is not what we're talking about when we're talking about the dangers. The danger, Will Robinson, of epinephrine is that is when a neuroendocrine patient that is syndromic, the people that are most at risk are going to be people that are horribly syndromic, have high serotonin levels, and so therefore they're having trouble turning things off already. And now they've had a major stressor. They're bleeding after a trauma. So major stressor, and the EMS people are trying to manage it as if it's just bleeding. And therefore what will happen is that they will try to give things and they won't be getting the expectation. And so therefore the next medical decision they're making based on the trauma is going to be based on the fact that you aren't responding. Well, the problem is that if they're using certain things, in particular epinephrine, if they're using epinephrine under those circumstances, it's not that you're not responding, it's that you have different mechanisms are at play. Whereas so people will literally call me probably at least a dozen times a year because one of our patients is in an emergency room in septic shock because of a UTI. And I'm like saying, okay, I'm not denying they have a UTI. I'm actually not denying that they may be in septic shock. But I'm telling you, they could just as well have a UTI and then it's triggering a carcinoid crisis. And this is what you're going to do. You are going to do this, 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 and this. And then you're going to call me back because obviously they can't transfer them. They're like in septic shock. And sure enough, I would say that the vast majority of times they call me back and say, oh my God, thank God we called you. But that's why I say that neuroendocrine patients are disenfranchised, right? Because mainstream medical practice does not have a like, oh my God, you have a tattoo on your brain saying, oh my God, treat me differently. I'm a neuroendocrine, which is why for those patients, I do recommend them having a medical alert bracelet, of which just like the EMR, that is becoming so much more sophisticated. I find it hard to believe that we don't have the little, thing at the supermarket scanner thing that would be able to open up all of the critical things on people with severe seizure disorders or whatever it is. So I think that the whole medical alert system is probably getting more sophisticated too. But I think your manifestation of epinephrine, of carcinoid syndrome, is going to be very patient specific.
Okay. All right. Now we have a question. We have a patient with what would you do if your serotonin level is greater than 2,000? You're on lanreotide and Zermelo. What might be the next step?
Yeah. Well, so to that patient is that there's probably so much more to that story than a serotonin level of 2,000. So what you need to do, we have to say, okay, so what do we think is driving the serotonin level? Because I'm telling you, you can have very small volume disease, but that it can be spewing things out like at extraordinarily levels. And so you can have a super low grade, but super active or hot, spewing it out at all levels. I don't like serotonin levels over 1,000, no less serotonin levels over 2,000. So then what would we do? We try to figure out what do we think is driving the serotonin level. So then usually we need to get a PET. So what I could have included, and now I'm like thinking in retrospect, so I apologize, is the interpretation of the PET scan is also something that people don't understand because there are all these values, but those values are really just trying to tell me how somatostatin receptor avid or how hot that is. Well, so how active something is, it's usually going to be what we think is going to be driving whatever's happening to the patient. So if you have disease in the liver and serotonin levels that are very high, and you have a PET scan that's telling you that you have this sucker is an SUV of this, and this sucker's this, and this sucker's this, is that you don't necessarily need, that's when, once again, palliative intent, you don't necessarily need to go Braveheart style and try to go everything. You would just be saying, I want to try to see whether or not I can use some sort of additional treatment to drive that serotonin level down, because the serotonin level is then likely driving then the intestinal manifestations, of which we usually say diarrhea, but intestinal manifestations can also be horrible, crampy abdominal pain, nausea, things like that. So if you think that it's driving the intestinal manifestations, then I would be having a conversation. Well, perhaps it is unrealistic. It doesn't mean lanreotide is not working. It just means it's unrealistic that lanreotide would be able to do that. Lanreotide was not really tested on its ability to bring down serotonin levels. I think Zermelo seems like a 100% reasonable choice. One, because the mechanism of Zermelo is to try to drive serotonin levels down. But is it realistic to think that Zermelo plus lanreotide or Zermelo alone was going to have enough impact to drive that serotonin level down? So that is when we look at serologic markers, meaning it's not about progression. It's not about changes. It's about what it is about that case that we think is driving that serotonin level to be so high, and what other things do I have in our treatment options that would potentially be able to drive that serotonin level down.
Oh, very good, very good. Oh, this is an interesting one. I think it's related to something you mentioned before, but the patient's asking, does pancreatic net usually go to the lung?
Oh, well, that can go anywhere. So I think before we had these more sophisticated PET scans, we all kind of knew that neuroendocrine went to the bone. And then we were like, oh, how did we ever make a decision on this disease? Because you come up with all of these people that had bone involvement that wasn't even symptomatic. So the lung itself, so let's just say the difference between the lung, the substance of the lung, and lymph nodes within the chest, it is not very common to see pancreatic neuroendocrine tumors or abdominal tumors go to the lung itself, meaning the lung parenchyma, the two things that are going up and down, versus going to the lymph nodes in the chest, which we will usually call it mediastinal involvement, hilar involvement, or chest involvement on the PET scan. It doesn't mean that it doesn't, because all cancers, especially cancers from the abdomen that funnel through the liver, they can then funnel through the liver and ultimately get to the lung, like colon cancer or garden variety pancreatic cancer. Oftentimes, if we think that is the mechanism, patients will not only have it in the lung substance, they'll have it in the liver substance as well. Now, how it goes about in the treatment of it, if it's in the substance of the lung versus the lymph nodes of the lung, probably doesn't change as much, other than my gut would say that we would have to talk about other systemic therapies, like a chemotherapy option, because you would have to appreciate the fact that it's actually within the substance of the organ, and therefore growth within that organ may cause lung related issues. If it's somatostatin receptor avid, then PRRT becomes a great option for that. But that it is unusual to get metastatic neuroendocrine to the lung substance instead of the nodes, but it's not unheard of. But that would be a unique feature of that case that would probably weigh heavily into the treatment options that we would use.
Okay. Okay. This one seems like a standard, so it's probably a good one to mention. Patient with ileum primary, multiple liver mets, 18-year survivor. She's what markers are important for them to follow?
Okay, so give me the primary site is what?
Is the ileum.
Okay. Yeah. So if we were to say, what is the agreement? So the two largest neuroendocrine programs in the country seem to be the only two that seem like steadfast on continuing to follow one of a number of markers in neuroendocrine patients, almost regardless of primary site. Now, I will tell you is that I think I think Rocky Mountain also does follow markers. But so Iowa and I are in agreement that having inherited, so I did not routinely check markers in patients once I understood that they were of a predictable biologic behavior, because I didn't think it really changed what I was going to do, watchful waiting versus treatment or whatever. But that in midgut, I think we're all in agreement, and that in midgut, I think they are more helpful at assessing any impact of what it is you're doing, but they're also helpful in understanding people's symptoms, because it's not like neuroendocrine patients can't get other diagnoses. I don't know, diverticulitis, Crohn's, whatever it is. And so we keep targeting, say, oh, it's got to be neuroendocrine, it's got to be neuroendocrine. And so those markers are actually extraordinarily helpful in a patient population that may have symptoms related to other diagnoses. And we keep, harping on the neuroendocrine component and or changing treatment on the neuroendocrine component and wondering why it's not working. So I think that the biomarkers, in particular, the ones that we're using, like the 5-HIA, serotonin, chromatin, and 5-HIA, those are, I think, most helpful in midgut primaries. Now, in the other cases, I will get them at baseline, but if they are normal at baseline, tumor markers in other cancers that are normal at baseline, it just means they aren't helpful to us, and so therefore following them is not going to be helpful either. That's where I think that there's a lot more of the debate within the neuroendocrine communities on why we just routinely use them in surveillance. And I would say that I think it's a generalization to say that we actually routinely use like treating everyone as a cookie cutter. I think that went out of favor in neuroendocrine, probably at least, 5 years ago, if not, in my lifetime in neuroendocrine. I think that the whole cookie cutter approach kind of went out the door, and we were really patient specific. And when it comes to biomarkers, I think it's the same way. We're just sort of more patient specific. Often disease specific midgut is definitely more helpful than pancreatic. But the problem with pancreatic is that no marker. So we definitely follow gastrin in gastrinomas. It's an exceptional marker and can often be the first sign that something is brewing. We definitely use VIP and VIPomas. It is an excellent marker, but that does serotonin and some of those other midgut valuable markers actually make a difference on what we do in pancreatic? Not very often. Not never, but not very often. It's certainly not often enough for us to say, oh my God, make sure you get your markers like on the day. No, we just don't generalize it by that anymore. That's what I think that we'd all agree on, even though it sounds like we're debating things more than we are. I think we all agree that the generalized use of markers does not often change medical decision-making.
Oh, perfect. Very good. But before we get our final questions, I just want to mention to everybody, Dr. Maluccio will be speaking at the National NET Cancer Patient Conference in Atlanta. I believe you're planning to be there all 3 days, November 10th through the 12th. And there'll be another 20 speakers or thereabouts with excellent credentials like Dr. Maluccio. So it's a fantastic event. Not only that, but you'll get to be there with a couple hundred other patients. So if you have the chance, we should definitely see you there. I'm not going to spend the whole time promoting it. Obviously, I am promoting it, but if you haven't been to one, you just don't understand. It's amazing when you get there. So you can register, of course, on our website, or you can reach out to us and you can get more information. It looks like we have time for 2 more questions. One, you had mentioned that you didn't like to see serotonin over 1,000. Do you have a number in mind?
No, I don't. So I will usually, tell people. So, and of course, there's not a difference between 999 and 1001, but that carcinoid heart disease can be an extraordinarily challenging additional component of patient management that we would just prefer to avoid if at all possible. So there is no magic number on whether or not, if you ride serotonin levels of 2000, that you will definitively develop carcinoid heart disease. It's just that we don't often see carcinoid heart disease in people that don't have significantly elevated serotonin levels. It just adds an extra level of complexity, because then we absolutely have to follow echocardiograms in order to better understand what's happening at the heart valve level, and then what are we then waiting to see before we would then all of a sudden start to have to intervene. So it's just one of those things where serotonin levels that are extremely elevated as some component of a disease process is going to have consequences. And so how I kind of describe it to people so that they understand the concept of that is that our body is it's functioning under a certain physiology day in and day out. And we're trying to react to an environment and keep everything in balance. And we understand diabetes. And so for the people that have diabetes, you know that your primary care doctor is like harping on your A1C. So diabetes is not about an individual glucose value at any component of your day, because you could be doing awesome one day and doing horrendous the next day. And overall, it's going to manifest in this glycemic index, which is the A1C. The A1C is what your body is living under steady state day in and day out. And we know that A1C levels above 7 are going to increase someone's risk of complications of diabetes, eyeballs, heart, kidneys, nerves, things like that. And so the issue is that we understand A1C and we don't as well understand serotonin levels, and serotonin levels and carcinoid syndrome patients are once again kind of outside of mainstream medical practice to say, oh no, boom, we are not going to accept 2000. We're not going to accept 1000. Oh, no worries. Your heart looks fine. We're going to accept 2000. It's an entirely different beast. And so that opinion on that variable alone is going to be completely irrelevant to Joe Schmo over here with neuroendocrine that has serotonin levels that run in the 600. It just is. And so I think that is an example of where there has to be a more in-depth conversation about any of the data that we have on the consequences of running a serotonin level above a certain level. But in someone's mind, they have to have some cutoff for me to say, okay, I don't like that it's 800, but my cutoff has been around 1000, not because people with 800 don't get carcinoid heart disease or people with 1000 do. It's just that we all have to have our threshold whereby we would raise enough concern that we do something about it. And my trigger point is 1000, where I start looking more closely at what I think is driving that and what could I do that I would be confident would be able to drive that down. But I don't think that medical management, when you have levels that high, I would have to look at the Zermelo data, but I don't believe that it would have been realistic to think that Zermelo was going to bring down a serotonin level of 2000 down into what we would consider a more reasonable range. But it's all about carcinoid heart disease. Well, and obviously about carcinoid syndrome and malabsorption and nutrition and stuff like that. It's usually about carcinoid heart disease.
Okay. We have someone with a rectal net resection, and then one of my least favorite terms as a patient advocate, no evidence of disease. Not that it's not literally true, but it suggests to them that they don't need to follow this thing, which fortunately it appears they're looking at it. Back to symptoms, and want to know if they should do more tests.
So I say yes. So it doesn't mean I would still be having a conversation about all the reasons why whatever those symptoms are unlikely to be related to a rectal net, but that that rectal go back to the pathology report, and we look and we say, okay, well, a grade 1 well-differentiated sub-centimeter rectal net, completely excised, margin negative, is as close to one and done as we've got. But the fact is that we actually don't understand why people get rectal nets, because that's a part of your body that doesn't really have significant neuroendocrine function. It's got like one function alone, that's like pushing poop out of your body. So then that's why the surveillance of rectal net is somewhat different in that if we don't know why you got that one, then whatever the risk factors were that drove you developing that one are still going to be present. It doesn't mean that the rectal net is more, aggressive, or that there's not, something else going on. So what I would say under those circumstances is that whoever gave you the discussion, it was probably a very benign, very, very bland looking tumor, and that rectal nets are usually followed with a repeat endoscopy 6 months after the diagnosis to determine that area had been completely excised. And then a year after that, so it puts us at around 18 months, to determine, now that we're going in with that in mind, to look at that remnant rectum. And then, depending on particular patient variables and symptoms, we will either cut bait and just kind of knock on your door and see whether or not you're having symptoms next year, or we would continue with surveillance scopes depending on unique variables. But now when you say, I didn't have symptoms, incidentally found on a colonoscopy, that happens all the time, and now I have symptoms, well, it is kind of the obligation of either someone in my position or whoever's taking care of you to put it into the context of a diagnosis that you previously had, even if they think that the link is likely going to be unrelated. But then you wouldn't just blow it off. You wouldn't just say, oh, I think it's going to be related to your neuroendocrine, but it's not going to kill you. You wouldn't say, I don't think it's related to your neuroendocrine, and then blow you off. They're going to have to either put it in perspective of the disease that you've got, or they would have to look more closely at what they think is driving it. And that would usually start with a repeat scope to better understand whether or not there's something there in the same location, and then some blood work.
Okay. All right. And I believe this is our final question. Do you recommend getting an echocardiogram?
Yeah. So I think that most of us are in agreement that a baseline echocardiogram on someone with what we believe is a serotonin producing tumor, like the mid guts, is a very good a baseline from which then future echocardiograms would be compared. The reason we do that is because even if your serotonin level is 400, 200, 600, whatever it is, these grow so slowly over time. We have no idea. Your body could have been living under elevated serotonin levels for a lot longer than we knew, because that's the way some of these neuroendocrines will manifest. So we get a baseline echocardiogram. Now, I think some of the people where I've rocked a little bit of their boat in taking over for Gene Woltering is that he would routinely check echocardiograms every year on the, in particular, the mid guts, but that even after they had been successfully treated. And so if you do not have any changes in your neuroendocrine blood work, or you do not have any additional symptoms, carcinoid heart disease is predominantly driven by elevations in serotonin levels. And so getting routine follow-up echocardiograms are actually not ingrained in our guidelines. Getting follow-up echocardiograms on anyone that has valvular problems is part of our guidelines. And getting a baseline echocardiogram is one of those things that's at the discretion of the provider that a lot of us find as helpful information, because if you were then to develop symptoms as you age, they could be heart related, they could be valve related, they could be neuroendocrine related, they could be serotonin related, and not having the thing to compare it to then doesn't give you that baseline. So baseline, yes. Routine in everybody, no. And for people with elevations in serotonin level, especially ones over 1,000, yes. For people that have any other things that would be overlapping with cardiac symptoms, that's the first go-to thing. But that I think, once again, it's going to be patient specific, because it's not actually spelled out in any neuroendocrine guidelines. And so, say, for example, for non-functional pancreatic neuroendocrines, there would actually be no guideline for echocardiogram that I can think of off the top of my head. But But a baseline, yes. And then routine and everybody going forward, no.
Well, I think we spent a good long time getting educated here, and I know that we're seeing a lot of great thank yous in the chat, and we certainly appreciate you coming out on a Saturday and speaking with everybody here today. You certainly didn't have to do that, and we appreciate that.
No, it's actually my pleasure, and I'm more than happy to communicate with anyone. I have my email or some of those phone numbers. They all take text messages as well, because a lot of questions. I think when people are hearing a talk, it's just human nature to see your situation, and you're like, how does that fit in with my situation? And those are just the questions that are sort of difficult to get into a forum like this, but maybe very patient specific, and that's what we're here for.
Well, thank you, Dr. Maluccio. We truly appreciate it. We can't wait to see you in November.